The most important topic right now we have, unfortunately, this is the final session. So I would like to request Dr. Sayantan Banerjee to please come on dais as our chairperson. Dr. Sayantan Banerjee is an associate professor, Department of Microbiology, AIMS Kalyani. And I request Dr. Nitin Gupta for a session on choosing antibiotic in resource limited setting.
So good evening everybody. I'm going to talk about basically how to choose antimicrobials. And so to just make this interactive, if you can just open your mobile and just scan this barcode. The idea is that I have certain case scenarios that people who work in tertiary care settings will encounter. And so the idea is just to discuss what would be a good approach. If you're not able to scan, you can go to the website menti.com and use this code 44086673. Right. So I'll start. So the layout is that this is going to be a case-based discussion, and most of the cases are patients who are critically ill who present to tertiary care settings. And the idea is that the antimicrobial resistance status in India is such that there are no clear-cut guidelines for a lot of these cases. So the idea is that I'll try and take you through what are the thought processes that go behind choosing an antibiotic in such patients. So there isn't a right or a wrong answer, but the idea is that we'll dissect what would be a good approach. So I have divided this 1-hour workshop into 2 parts. So the first part is there are 4 syndromic cases which deals with antimicrobial resistance, and there are 4 tropical infections which are very common in all parts of India, and this is my area of interest. So we'll try and finish off these 4 cases in 30 minutes each. So let's start with the first case. This is a 34-year-old female patient, type 2 diabetes mellitus, has come with fever with chills and rigors. There is some increase in urinary frequency, dysuria. There is flank pain. On examination, you see that BP is 80 by 60 millimeter of Hg. Now, what will be your empiric choice of antibiotic? Is it meropenem, piperacillin, tazobactam? Do you want to give meropenem plus vancomycin, or you want to give nitrofurantoin? So now is the time to put in your answers. Right, so I see a majority of the audience has chosen nitrofurantoin. So I'll come back to why nitrofurantoin might not be a great option here. So when I choose an antibiotic, I look at 4 things predominantly. First is, what is the syndromic diagnosis? So here, in general, if you want to see UTI, you want to divide it into an uncomplicated and a complicated UTI. Basically, there are a lot of previous definitions. Now, the idea is very clear. So, the idea is basically very clear right now. If a patient has fever with urinary symptoms, you are looking at an upper UTI, you are looking at a complicated UTI. So, if a patient comes with urinary symptoms, has fever, you are thinking of something that is above urinary bladder. So either there is a ureteritis or there is a pyelonephritis. So this is something that we have established. So nitrofurantoin, for example, does not work for upper UTIs. So it can be given for simple cystitis. It works well. It doesn't even work for male UTI. So the only place where you would want to give nitrofurantoin would be females with simple UTI or uncomplicated lower UTI that involves bladder or urethra. So when we talk about complicated UTI, we are basically talking about either pyelonephritis, or in males we can also talk about prostatitis. The second question that you want to ask is whether the patient is critically ill. Now I've showed that the patient has hypertension here. So I'll assume that the patient is critically ill. Why is it important for any case that comes to you? Is because if the patient is critically ill, you don't have the time to test that. Let me start with a lower antibiotic, and when the patient worsens, you don't have that much time. So in a patient who's already in sepsis, every hour delay in the correct antimicrobial choice is going to lead to higher chances of mortality. So ideally, you are interested in giving the first shot should be your ideally best shot. The third thing is, what bugs are you suspecting? This is very, very important. Your choice of antibiotic is going to be dependent upon what bugs are you suspecting here. So this is a patient where you are suspecting an upper UTI. Now for upper UTI, the most common organisms are this. You have organisms from enterobacteriales, Escherichia coli, Klebsiella pneumoniae. The second probably would be Enterococcus. Staphylococcus is very, very rare. It's not very common. In general, what happens is Staphylococcus is a descending UTI. Patient acquires Staphylococcus from another route, and it can then come and involve the urinary tract. Here, more than 80% chance that this is going to be an Enterobacteriaceae, and good 60 to 70% chance this is going to be an Escherichia coli. So for a patient like this, and if you see the last ICMR available surveillance data, you will see that 80% of these are gram-negative Enterobacteriaceae. And therefore, the one of the options was Mero and Vanco, which nobody chose. I would not give vancomycin in a patient where the source of infection is a urinary tract infection. So here, the choice remains between piperacillin tazobactam and meropenem. And this is where your hospital antibiogram will come to aid. Now, if you're working in a setting where hospital antibiogram is not there, this is a difficult scenario because the hospital antibiogram is something that helps you in choosing what antimicrobial you want to give. If you don't have, then you have to go with the data of the nearest medical college where that hospital antibiogram is available, or you can go to the ICMR data. This is why you cannot use IDSA guidelines or a European guideline and use it in Indian settings. Our AMR status, antimicrobial resistance status, is really, really bad, and we have to deal with our settings in our own manner. So if you see the susceptibility data here, you will see cefotaxime, ceftriaxone or cefotaxime, there is only 18% susceptibility for E. coli, which is the most common organism here. If you see piperacillin tazobactam, the susceptibility is only 35%. So if a patient comes to you with urinary tract infection and shock, and if you are choosing piperacillin tazobactam, there is a 65% chance that it is not getting covered. With meropenem, this is still less, but it is good enough. So 70% at least susceptibility is there. This data will vary from settings to setting, but when I choose meropenem, I am at least improving my chances. Now the point is that, let's say you get a susceptibility report and piperacillin tazobactam is susceptible. Even then, piperacillin tazobactam would not be a great option. So there is a Merino trial that published, this is long back, but the data still holds true. So Merino trial, basically what it did was, in a patient with E. coli or Klebsiella, if you have susceptibility to piperacillin tazobactam and meropenem both, the mortality with piperacillin tazobactam was higher. Basically, this is what we call as the ESBL type of organisms. There, piperacillin tazobactam is associated with higher mortality. So in this case, even if piperacillin tazobactam was susceptible, the chances of susceptibility is anyways lower. Even if it was susceptible, meropenem would be a better option. Right. So I'll start with the second case. This is a 65-year-old male who was presented to you on a Saturday night. Now, patient has come with fever and headache. Now, this Saturday night, I understand that for private practitioners, Saturday and Sunday do not matter, but suppose you're working in a medical college setting where on Sunday, a lot of things won't happen. So patient has come with fever and headache for 3 days, has an altered sensorium, and there is neck rigidity. Now, you know that the syndromic diagnosis here is an acute bacterial meningitis, possibly. It could be a viral meningitis also, but the most likely diagnosis here is an acute bacterial meningitis. Now, what antibiotic regimen will you advise? Will you give ceftriaxone alone, ceftriaxone and vancomycin, ceftriaxone, vancomycin and ampicillin, or vancomycin alone? So, choose your answers. So there is a split between ceftriaxone alone and ceftriaxone, vancomycin and ampicillin. So in let's say 60, 70, 80% of the cases, depending upon the resistance there, ceftriaxone should work. But I'll tell you why I would choose ceftriaxone, vancomycin and ampicillin here. If you see, this is the latest available ICMR data. The most common organism for acute bacterial meningitis is strep pneumoniae, pneumococcus. And Neisseria meningitidis is usually happening in outbreak settings. Haemophilus influenzae is also there, but most common is pneumococcus. Now the thing is that why I would choose ceftriaxone, vancomycin and ampicillin is that ceftriaxone covers both pneumococcus, meningococcus. It will also cover Haemophilus influenzae. Vancomycin, contrary to the popular belief, people feel that we add vancomycin for MRSA. No, MRSA is not there as a causative organism for community-acquired bacterial meningitis. You are more worried about penicillin-resistant pneumococcus. So the rate of this penicillin resistance in pneumococcus varies according to settings, but it is anywhere between 10 to 20% in major tertiary care hospitals. The third thing here is that this is an elderly patient. So Listeria is an organism that basically is a causative organism for acute bacterial meningitis in extremes of ages. So very young individuals and people who are elderly, there is a problem of Listeria. It is not very, very common, but it is something that you would want to cover. Again, acute pyogenic bacterial meningitis, whatever the presentation, it is a patient who is critically ill. Every hour delay in the correct antimicrobial is going to lead to, if not mortality, morbidity. So you would want to cover all these three organisms. Another point is that this is your empirical antimicrobial of choice. Now, you were able to get a CSF and you see that this is suggestive of an acute bacterial meningitis. There is high CSF pleocytosis, most of it is neutrophil, protein is a little high, glucose is low, basically suggesting that this is acute bacterial meningitis. Now, by the time you got a CSF, you have already got a blood culture report. Now, you see that the blood is growing Streptococcus pneumoniae. So, this is good enough to say that this is pneumococcal meningitis, because the patient has come with acute bacterial meningitis. Even if the blood is growing pneumococcus, you are sure that this is pneumococcal meningitis. Now, I've just put this case. This is a one-off scenario, but this is something where I want to introduce the concept of MICs. For general practitioner, usually MIC is not important. You can see if the lab is reliable, it is sensitive, resistant, and you go with whatever is sensitive. The numbers are not important. But there are some specific scenarios where these numbers are important. And this is one of the scenarios where these numbers are important, where labs, if they commit a mistake, it is going to be really harmful for your patient. So I will not be able to discuss all the specific scenarios, but I'm just giving an idea. So here, just look at the MICs, and I'm going to talk about why this is important. So now that you have got a report of pneumococcal meningitis from blood, and you have seen that they have reported it as ceftriaxone sensitive. Now, do you want to de-escalate? So the idea of, again, antimicrobial therapy is that you start with the broadest empirical antimicrobial regimen that covers all your organisms, and then you come down. You do a targeted therapy, and that is dependent upon what is your susceptibility. Right? So in this case, ceftriaxone is susceptible. So would you want to de-escalate is the question. So do you want to give now again ceftriaxone plus vancomycin, or you will continue the same regimen, or you will de-escalate to vancomycin? So the answer that ceftriaxone, vancomycin and ampicillin would not be correct, because right now you have gotten the diagnosis of pneumococcal meningitis. So Listeria is not a question for you. So anyways, ampicillin does not need to be continued. The choice appears that ceftriaxone is the right choice because it is showing sensitive in the report. But the answer is actually ceftriaxone and vancomycin. And the reason is that the clinical breakpoints for Streptococcus pneumoniae in blood and CSF differ. An antibiotic might not reach CSF at the levels you want. So this was susceptible according to the blood report. But if you interpret this according to the CSF breakpoints, it is resistant. The idea just here is that sometimes knowing the MIC clinical breakpoints for a particular syndrome is important. So here they showed ceftriaxone was 1, the MIC was 1 and showed it as sensitive. But if you interpret it according to the CSF breakpoints, it is resistant. So the idea is that if you have a confusion, contact your local ID person. And here the ceftriaxone and vancomycin would be still the targeted choice. If the MIC was less than 0.5, you could have gone and de-escalated to ceftriaxone. Now this is the third case. This is a 45-year-old diabetic male, has come with severe pain, redness over the right arm and has fever. Patient has no history of animal bite or exposure to water. Basically, if there is an animal bite, you look for different organisms. If there is history of exposure to water based on fresh or seawater exposure, you have different organisms. But this is a garden variety, severe pain, redness over the right arm. The patient is a diabetic male. And you see the patient is critically ill, has hypotension, tachycardia, tachypnea. And there is crepitus on examination, skin discoloration, and foul smelling discharge. Now the question is, what is the treatment here? Now, basically, I'm directing you towards a complicated skin and soft tissue infection. This is very likely to be a necrotic soft tissue infection. So what would be your treatment of choice in this case? Meropenem, Mero plus Clinda, Mero plus linezolid, or piperacillin tazobactam would be good enough. Please type in your answers. Right, so most of you have chosen meropenem and linezolid, and that is the right answer according to me. The idea is that skin soft tissue infection can be either superficial or it can be deep. When it involves the fascia, it is actually an acute emergency. One, your surgeons have to be involved, and second, you have to start with the right antimicrobial therapy. And basically, in my case, I have put all scenarios that will suggest that this is a necrotic soft tissue infection. Now, the causative organisms, the two main causative organisms are group A Streptococcus and Staphylococcus aureus. But you have to also cover for anaerobic organisms. In India, actually, gram-negative Enterobacteriaceae is also something that you have to cover. So I wanted to give meropenem because meropenem will cover your gram-negative Enterobacteriaceae. Meropenem has good anaerobic coverage. In general, meropenem has good anaerobic coverage. Meropenem will take care of your group A Streptococcus, and it will take care of your MSSA, Staphylococcus also. Now the thing that is left is MRSA, methicillin-resistant Staphylococcus aureus. For that, you have to give an anti-MRSA. You can go with vancomycin, teicoplanin, clindamycin, or linezolid. Clindamycin is often sensitive, but it will depend upon your scenario. So I would not want to use clindamycin if I am not aware of what is your scenario. Now the choice is between vancomycin, teicoplanin, and linezolid. The thing with necrotic soft tissue infection is that there is a lot of local toxin production, which actually, when there is shock, you should think that there is a toxic shock syndrome going on because these organisms are liberating toxins. So when you are giving an antibacterial, it is going to kill that bacteria, but that toxins have to be neutralized also. So the antibiotic that you are using should have an antitoxin activity also. So between vancomycin, teicoplanin, and linezolid, actually linezolid has antitoxin activity. So here the answer would be meropenem and linezolid. If you want to use a teicoplanin, then you have to add an antibiotic that has an antitoxin coverage. So in that case, you can use meropenem, teicoplanin, and clindamycin. So these are again all critically ill patients. For a patient with cellulitis, you can just start with ceftriaxone. That is good enough. But if you have a patient with necrotic soft tissue infection, again, delay is going to result in loss of arm or leg wherever it is involved. So the idea is that there are certain pointers. Not all of them will be present. So first is that usually there will be no sharp margins. Like you can have in erysipelas, you can have sharp margins. Sometimes cellulitis also there can be sharp margins. There is a lot of edema. Patient has disproportionate pain. There is fever. Crepitus is something, basically crepitus means there is gas formation there. So anaerobic organism, Clostridium is known for gas formation. A lot of enterobacterials which cause gas formation. And if there is bulla is more commonly seen with staph. So, or often you will see necrosis also. So when you see all these things, or any of these things actually, the suspicion for a necrotic soft tissue infection or necrotizing fasciitis should be very, very high. And in that case, you start with an empiric antimicrobial. After your first debridement, if you see, let's say, it comes as group A Streptococcus, then you can de-escalate to a ceftriaxone, but you would want to give an antitoxin for a few days at least.
So should we wait for this, report of culture?
No. So these are all empiric. As of now, so I'm talking about two therapies. One is empiric therapy, where when the patient comes to you, you assess quickly and you start your empiric antimicrobial as early as possible.
And you can go for debridement as well.
Then you go for debridement, you get a culture, and then based on the culture, you can take a call, and also on the response to the initial empiric antimicrobial therapy. So this is the fourth case. So this is a 30-year-old patient has come with fever, cough, expectoration, there is some breathlessness, and you see hypoxia. So this is clearly a community-acquired lobar pneumonia. Now, what antibiotic will you start? Are you okay with a ceftriaxone, piperacillin, tazobactam, azithromycin, or you will give ceftriaxone plus azithromycin here? Right. So there is an overwhelming majority of ceftriaxone and azithromycin. And I'm glad that people have not chosen piperacillin. Okay. So piperacillin, tazobactam is not required in this case because the most common organism here would be again pneumococcus. Strep pneumoniae is the most common organism. Haemophilus influenzae can be there. Most of these are covered with ceftriaxone alone. So piperacillin tazobactam is not required in most cases of community-acquired pneumonia. Now, why have we added azithromycin here? So if you see the most common organisms, and this is a division of the most common organisms in community-acquired pneumonia according to the geographical location. And if you see in Asia, the two major things that come out is, one is pneumococcus and the second is atypical organisms, so Mycoplasma chlamydia. Problem is that there are no reliable tests in general in resource limited settings to diagnose mycoplasma and chlamydia, and therefore when you are treating a patient with community acquired pneumonia, even if it is a low bar consolidation, you have to cover for an atypical organism. There is usually a dogma that atypical organisms will have interstitial infiltrates, not necessarily. So here you want to cover both pneumococcus and mycoplasma. And like I said before, that in pneumococcus there is penicillin resistance. So this varies from place to place. There is resistance to ceftriaxone. So in pneumococcus there is penicillin and ceftriaxone resistance in the level of 10-15% depending upon your setting. There is resistance to azithromycin. So one, when you're combining both ceftriaxone and azithromycin, you're giving a better cover for pneumococcus. And second, azithromycin will take care of your atypical pneumonia. So this is something that you can start. Once you get a susceptibility report of pneumococcus that is susceptible to ceftriaxone, you can stop azithromycin, that is okay. Doxycycline is good enough. There is no clear benefit of azithromycin over doxycycline. Most of the trials use azithromycin, therefore there is use of azithromycin. And I have kept the later half of the presentation on tropical infections and where I would delve more into why doxy, why azithro, and because a lot of tropical infections can also present with community acquired pneumonia, where I am going to talk about this. So this patient, you started on ceftriaxone and azithromycin, the patient is improving. Now after 4 days of hospital stay, you have discharged, but the patient comes back again within 24 hours, and now you see that the infiltrates are in a separate different location. Now what empiric therapy will you give? Now this is clearly a hospital acquired pneumonia. The patient has come back to you within 24 hours and there are new onset infiltrates, new onset fever after the patient has improved. So now what therapy will you give? Meropenem, piperacillin, tazobactam, polymyxin, or none of this? Now this is where this will depend the choice of the antibiotic will depend very highly on where you are working, what is your hospital antibiogram. And ventilator associated pneumonia or hospital acquired pneumonia are very difficult to manage, and I will try to give an answer, but the answer is not very simple or clear. So we will talk about this. So there are people who have chosen none of these. Most of the people have gone with meropenem, some have gone with piperacillin tazobactam, and some have gone with polymyxin. And I'm going to talk about why I think what would be a good approach to deal with hospital acquired pneumonia. Now in general, there are 3 main causative organisms for hospital acquired pneumonia or ventilator associated pneumonia in our setting. So, and the most common organism would differ from settings to setting. So first is Klebsiella pneumoniae, second is Acinetobacter, and third is Pseudomonas. And the idea is to cover all 3. Now IDSA recommends that your empiric antimicrobial should cover 95% of the possible causative organisms, which is it's actually impossible to do that in Indian settings. So we'll go with the best possible option that we can do. Now if you see Klebsiella pneumoniae, this is ICMR data. Now the resistance to susceptibility to piperacillin tazobactam is 23% for Klebsiella pneumoniae, and for meropenem is 31%. So clearly both piperacillin tazobactam and meropenem is going to miss more than 70% of your organisms very easily. So it's not a good option. If you see, the third option was polymyxins. If you see, the mortality with polymyxin is close to 57% with polymyxin combination therapy also. So even if polymyxin is susceptible for Klebsiella, you'll see the susceptibility report shows 92% susceptibility. First thing that I want to say is that your routine commercial labs, if they don't do a microbial dilution test, which most of them do not, you will not get a reliable susceptibility to colistin. If somebody is writing sensitive from a Vitek report, it's not correct. So first of all, you're not getting a reliable report of colistin. Second, if you assume colistin is susceptible, if you give colistin or polymyxin as monotherapy or combination therapy, your mortality rates are still very high. So all the 3 options that I've given, with the first organism only, I am not happy with the outcomes that you're going to get. With piperacillin tazobactam and meropenem, your coverage rates itself is less than 30%. With polymyxin, your mortality is close to 57 to 60%. So are we happy with the odds is the question. So for Klebsiella, we have a possibly correct answer. So there is a combination of antibiotics that is something that is going to be helpful, is ceftazidime, avibactam, and aztreonam. I'm not going to go into the molecular resistance patterns in Klebsiella and why this combination is used, but this combination works for most Klebsiella pneumoniae, ceftazidime, avibactam plus aztreonam. And this is the meta-analysis that we did, and we found out that it is clearly better than polymyxins. Granted, most of the data comes from observational studies, one of which is ours also, but there is a clear-cut benefit with use of ceftazidime, avibactam, and aztreonam for Klebsiella. So, if your hospital shows that Klebsiella pneumoniae is the most common organism for hospital or ventilator-associated pneumonia, your antimicrobial regimen, empiric antimicrobial regimen, should consist of ceftazidime, avibactam, and aztreonam. But the other thing is also true that there is a lot of misuse of this antibiotic, and therefore this should be used judiciously. Now we come to the second organism, which is Acinetobacter. Now Acinetobacter, if you see susceptibility for Acinetobacter for both carbapenems and piperacillin tazobactam is a meager 6%. So if you give piperacillin tazobactam or meropenem, there is 94 to 95% chance that it is not covering your organism that is there, and which is again a grim scenario. Polymyxin, again, we don't have reliable susceptibility, but in general, polymyxin is susceptible for Acinetobacter. So polymyxin-based combination will work, but again, like I showed, polymyxin for Acinetobacter alone also is not a great option. So for Acinetobacter, actually, whatever evidence we have, at present, your therapy for Acinetobacter should contain a sulbactam-based regimen, along with that, possibly polymyxin or tigecycline or minocycline. So sulbactam plus either of the three antibiotics is something that should work for Acinetobacter. Now the problem is that most of you use, or most people use cefoperazone sulbactam, and you use it at a 1.5 gram BD or 2 gram BD or 3 gram BD, where you give sulbactam of 3 grams or 2 or 3 grams per day. The recommendation for sulbactam is 9 grams per day. In fact, there is an RCT where they compared 9 versus 12 grams, and 12 was found to be better, but you have to at least try and reach somewhere between 6 to 9 grams. So there is sulbactam available. Now this is very, very scratchy data, but we are dealing with a situation that is very, very common and hardly any data. So at present in Indian setting, sulbactam-based combination with either polymyxin, tigecycline, or minocycline based upon your susceptibility pattern. The third organism is Pseudomonas. So in Pseudomonas, you will see that the susceptibility is actually a little better. So piperacillin, tazobactam, and meropenem have some chance of success. But the thing is that in bigger, high, low tertiary care settings, the susceptibility for this is also coming down. For Pseudomonas, choosing a therapy is very, very difficult. You should know that tigecycline, if you use for Acinetobacter, tigecycline does not cover Pseudomonas. So the idea is that this decision is very, very complex. And it has to be chosen based on what is your most common organism in the hospital that you are working or where you are visiting. And so in my hospital, for example, Klebsiella pneumoniae is the most common cause for hospital-acquired pneumonia, and therefore I use a therapy which consists of ceftazidime, avibactam, and aztreonam. The second agent that I add on top of this is dependent upon what is my second organism. So usually I go with either a polymyxin or tigecycline. So with this, I am finishing the syndromic part of this. Now I'm going to just take you through quickly some tropical infections, which is again, in the monsoon season, it comes in high numbers. So the idea is also to identify these tropical infections and choose the therapy. For tropical infections, you don't have issues with resistance. Most often, if you identify the infection, you are able to give a proper therapy, and usually they are very, very gratifying to treat because the response is very, very acute. So this is a patient who has come with fever and dyspnea. Chest X-ray shows perihilar infiltrates, and there is tachycardia. Now the thing is that how is this different from a community-acquired pneumonia? Because how we define this is as this is an acute febrile illness. Patient has come with fever. There is multi-system involvement, and in the laboratory you will see that there is some bit of thrombocytopenia, and either there is leukopenia or leukocytosis, and you have a little bit of transaminitis. So this is a patient who has come with acute febrile illness. Now 10-15 years back, depending upon the region where you are working, malaria would be the most common organism. But now, for example, in my setting, in 5 years, I have seen 3 malaria cases. So malaria has come down. But in Calcutta, this might not be true. Malaria is still a common organism, and it is easy to diagnose. So what you can do for malaria is send a simple rapid diagnostic test. In general, it will work. So in general, if it is malaria, it will be positive. So for this patient, rapid test for malaria was negative. Now there is this outside report for Vidal, which is positive. So in general, Vidal is a useless test. Positive, negative does not make any difference. So a positive Vidal or a negative Vidal has no bearing on the diagnosis. So Vidal should be ignored. Now what is the antibiotic that you start for this patient? Has come with an acute febrile illness, multisystemic involvement, there is some feature suggestive of ARDS, there is thrombocytopenia and increased CRP. So what antibiotics will you start here? Doxy, azithro, ceftriaxone or piperacillin tazobactam. There is an overwhelming majority for doxycycline. None of you have chosen azithromycin. So this patient basically, there was the trop T was also elevated, and basically there was some T wave inversions in ECG also. So this is an acute febrile illness with myocarditis with ARDS. So these are the possible organisms here. COVID, either we are not seeing or the government is not letting us test. So we will not talk about COVID. So dengue, I work in a setting where Cassandra-Forest disease is common, and this could very well be Cassandra-Forest disease. But dengue, influenza, salmonella, leptospirosis, scrub typhus, these are your major differentials that can present with these features. Now the thing is that this is the table that I've made just to talk about what are the clinical symptomatology of this, and based on the clinical features, can you come with a possible diagnosis based on clinical features and laboratory tests alone. Now, if you see, this patient had fever, there was cough, there was, I didn't mention any particular rash, I didn't say there was jaundice, I didn't say there was conjunctival suffusion. So the thing is that leptospirosis has two major presentations. One is Wheel syndrome, where the patient has liver, kidney and lung involvement. Liver and kidney is usually there. So you see a lot of conjugated bilirubinemia and you see acute kidney injury. This is actually in literature they say 10%, but in setting where I work, most of the patient presents with this. So a little less chance to be lepto. Dengue. So in dengue, usually you will not see, the most common presentation of dengue will be high-grade fever, and there is erythematous rash at presentation. This could be still dengue. Scrub typhus, the pathognomic sign for diagnosis of scrub typhus is an eschar. Now, the problem with an eschar is that eschar needs to be looked for in the right location. I'll show you in a slide. So, I'll show you a slide before I talk about this. And when you see the laboratory features, there are certain features that will help you. Leukopenia is something that you'll see very, very commonly with dengue or any viral infection for that matter. When there is a chikungunya outbreak, in chikungunya also, leukopenia is something that is very, very common. Leukocytosis, not that common, can be seen with dengue. But if you see a patient with leukocytosis, you're thinking more towards bacterial infection. CRP, actually in acute febrile illness, CRP has shown to have some diagnostic accuracy in differentiating viral and bacterial. This is not true for all infections, but for acute febrile illness, it might be helpful. So the CRP was elevated. This is again pointing towards a bacterial acute febrile illness. So the bacterial acute febrile illness is scrub, lepto, and enteric fever. Now if you see this is a typical eschar. Now you have to notice that it should not be confused with a scab. In an eschar, there is an erythematous halo around the necrotic lesion. So this is something that will tell you this is pathognomic for scrub typhus. If you see this is enough to make a diagnosis of scrub typhus. And scrub commonly presents with myocarditis. One of the target cells for scrub is myocarditis. Now this is a systematic review that I'm going to show. The prevalence of eschar in different regions in India varies, and unfortunately for West Bengal, it was very, very low. This is possibly for two reasons. One, either we are not looking properly, or second, the test that we are using is not specific enough. So any which way, this is something that it has to be corrected. For our setting, where there is a validated test, the scrub typhus frequency, eschar positivity in scrub typhus is close to 60 to 70%. The other important point that I want to relay is that look in the right location. So what happens is that the scrub typhus is caused by a mite. So the mite will latch on to you and it will start walking up. Wherever there is a tight clothing or wherever there is natural skin fold, it will bite there. So we will find eschars in groin, axilla, or wherever people wear a lot of lungis, it will be near umbilicus, or for women below sari, also in the breast folds. Unfortunately, these are all clandestine areas where people in a busy setting would not want to look. But if you have a febrile illness patient, you have to examine physically very, very properly, because that is going to change your outcomes. The mortality with starting a treatment for scrub typhus is very, very low. It is close to 1 to 2%. So if you have diagnosed a patient with scrub typhus who has come with like a community acquired pneumonia feature also, so we have had patients who were in ICUs but were walking after 2 days after initiation of therapy. Now the choice between doxycycline and azithromycin, and we did a systematic review meta-analysis comparing doxy and azithro. There is no difference between doxy or azithro. You can use it depending upon what you want. In this case, where there is myocarditis, if you want to avoid azithromycin, it is okay, you can use doxycycline. Previously, there was a dogma that doxycycline cannot be used in pregnant individuals or children. You can use it in any age. The duration of doxycycline is very low. 3 to 5 days of doxycycline, you can use it in any age and in pregnancy also. So in general, 5 days of doxycycline or azithromycin is good enough, and the response is very, very acute. Fever usually comes down within 48 hours. This is another patient who has come with fever and loose stools, and this is something that is very, very common, and I just want to point out that patient has come with fever and loose stools, and the patient has started with low-grade fever and is slowly increasing to high-grade. Now the pattern of fever usually does not have good diagnostic power, but it is a subtle finding. In viral fever, patients usually start with very high-grade fever up front, but in some of the bacterial fever, like enteric fever, it will start with a low-grade fever and slowly it will increase. It's a soft sign. Coated tongue also is not specific for enteric fever. It can be seen in any patient, but I am basically pointing towards a diagnosis of enteric fever here. Enteric fever can have both leukopenia and leukocytosis. Both are common, can have both diarrhea and constipation. So myriad manifestations, but will come with fever and multisystemic involvement. AST ALT is usually high by second week in most patients with enteric fever. Now, you have made a diagnosis of enteric fever and you have started the patient on ceftriaxone. You did a Vidal test. Now again, like I said, Vidal is usually not helpful. Whatever it comes, it doesn't matter. The diagnostic test for choice for enteric fever is blood culture. Unfortunately, either blood culture is not sent, or if it is sent, is not positive because patient has received some antibiotics, or even without antibiotics, the sensitivity to blood culture is not very, very high. So your blood cultures can still be negative. Now you have started ceftriaxone for the patient thinking that this is enteric fever, and there is no response after 3 days. You have evaluated for all the possible causes, scrub, lepto, malaria, everything is negative. Now what would you do? Would you add azithromycin? Would you change to azithromycin? Would you continue ceftriaxone alone? Or would you change to piperacillin tazobactam? So as of now, in many settings, in many patients, we still have to diagnose enteric fever clinically. And most often it is by exclusion of other diseases which have a good serology. So scrub typhus, leptospirosis, both have good serology. They can be excluded. Dengue can be excluded, malaria can be excluded. So enteric fever is often a diagnosis of exclusion, and you know the pattern of fever and GI involvement can be there with many diseases, but subtle findings that can help you in making a diagnosis. So we are sure that this is clinically this is an enteric fever patient. So
unfortunately,
are we not able to?
Yeah, this is not working.
Oh, this is not working. Huh? Anyways, so some people want to add azithro, some people want to continue ceftriaxone. What is important is the time to defervescence of fever. So for scrub, like I said, most patients will respond within 48 hours. Leptospira patient actually will not present with a lot of fever most often, and persistence of fever is not something that we are worried about in leptospira. In leptospira, usually it is that the persistent kidney injury, some patients require dialysis for long. But for enteric fever, actually, the major problem is time to defervescence. So for most antibiotics, the time to defervescence is 5 to 9 days. So it takes time for your enteric fever to respond. Problem here is that you don't have a culture positivity report. You don't have a susceptibility report. You don't know whether this is ceftriaxone susceptible. But if you see the ICMR data, you will see that ceftriaxone is susceptible for 86% of the patients, and azithromycin is susceptible for 96% of the patients. So there is a chance that this is ceftriaxone resistance, but it is too early to tell. So there is, there are reports of high resistance in Gujarat. There are reports of ceftriaxone resistance in Mumbai. Again, local epidemiology is something that is going to help. Azithromycin susceptibility is still better, but there are reports of emergence of resistance to azithromycin. So there are two ways I can handle this. One, my empiric therapy, I personally prefer azithromycin. One, it is oral. The time to defervescence is little shorter, and the resistance rates are a little better. The other thing is that if you start with ceftriaxone, if the patient is stable, you can actually wait out and wait for 5 to 6 days. Most of the times the fever comes down by day 5. But if you say I want to add azithromycin because the rates of ceftriaxone resistance is high in my setting, it would not be a bad idea now. There is a study from Nepal. Sorry? So the point is that the time to defervescence with azithromycin is also going to be 3 to 5 days. Now if you start azithromycin and the patient was actually resistant to azithromycin, patient was susceptible to ceftriaxone but was taking its sweet time to respond, it would not be a good idea to substitute. So if I have to, I will add. But in general, what we do is, because enteric fever patients are usually stable, if they are not doing bad, I will wait out for at least for day 5 and then think of adding azithromycin. Right. So I have started at 5:15, I will complete at 6:15. So this is a case, this is a 44-year-old male patient, has come with fever, low backache, orchitis, and you see this in the L4 vertebra, there is a hyperintensity in the anterior superior area. And you see there is pancytopenia. So in the interest of time, basically this is something that is called as the classic Pedro Pons sign. This is common in brucellosis. Now I am talking about this in West Bengal. In West Bengal, I have heard that brucella is very common. But the problem is that there is a tendency to overdiagnose tuberculosis in any patient who comes with TB with spondylitis or spondylodiscitis. So the idea is that brucella is not uncommon, and brucella when localizes, it very frequently localizes to the spine. So you should have an idea of how to differentiate TB and brucella, and then decide on what therapy do you want to give. So basically in this case, there are scoring systems that we have created. I'll show you the scoring system which can help you in differentiating between TB and brucella. Briefly, in TB, destruction is more common. So spine deformity, a lot of cold abscess, paravertebral abscess will be more common with TB. The classic location for TB is the lower thoracic vertebra or upper lumbar vertebra. If you see somebody with a lower lumbar vertebra with sacroiliac involvement, you should think of brucella. I will show you the scoring system, but this is something that is going to be helpful in differentiating brucella and TB. Now the treatment for brucella spondylitis is basically doxycycline, rifampicin, and streptomycin or gentamicin for 2 weeks. So I am assuming this is common in Calcutta, and this is something that everybody should be aware of. If this is not working, I am just showing the scoring system. Again, the problem is often that radiologists are also not aware of what the diagnosis is. If you don't go in, take a biopsy and culture it, or if you're not doing the appropriate serological test, you will often not know what is TB, what is brucella. And there is a tendency by radiologists also to overdiagnose brucella. So a scoring system that we have created based on objective MRI finding is something that is going to be very helpful. So we found out in our cohort of 120 patients that this scoring system has a considerable sensitivity and specificity, and the area under curve was 0.92. So like I said, if you have a patient who has thoracic spine involvement, has a lot of vertebral destruction, has a lot of disc destruction, spine deformity, and a paravertebral abscess, you should think more in the lines of TB. If there is not a lot of spine deformity, there is a little bit of cold abscess, but not a lot. If there is lower lumbar vertebra involvement, L3, L4, L5, there is sacroiliitis, you should think of brucella. And also brucella, there are some additional subtle pointers, like orchitis is more common with brucella. So, and this is my last case, and this is something that I want to leave with. So this is a patient who has come with, he's a farmer in rural West Bengal, has come and with a pain and swelling in the right jaw and cheek, is breathless, is hypotensive, and blood culture is positive for a gram-negative bacilli. On hospital admission, you have realized that the patient is diabetic and the HbA1c is very high. there is leukocytosis and high CRP. In the CT, you see something like a reverse halo sign. Anybody has an idea what the diagnosis is? So the thing is that this disease is not being diagnosed in West Bengal as often as it is diagnosed in outside settings for people coming from West Bengal. So the diagnosis here is milioidosis. It is not uncommon. It is very, very common in coastal areas. It is very, very common in areas where there is a lot of paddy farming. So any patient who comes with abscesses anywhere. So this pain and swelling in right jaw is basically because of a parotid abscess. So parotid, prostate, liver, spleen or lung. If there are abscesses here and if there are multiple abscesses involving 2 or more systems, you should definitely think of milioidosis. Milioidosis can come acutely as community acquired pneumonia also. So based on the setting where the patient comes from, you should definitely think of milioidosis. And the antibacterial that you would like to add here, either ceftazidime or meropenem, both of them works. But if you give something like ceftriaxone or piperacillin tazobactam, it will not work. So milioidosis has high mortality if not treated adequately. So this is something that you should keep in mind. So this is, in general, there is also a little bit of dogma that reverse halo sign means mucor. But this is a series of 8 patients that we published who came with milioidosis and had a reverse halo sign. So have a high suspicion for milioidosis, especially if the patient is uncontrolled diabetic and is coming from and is a farmer or a fisherman. So these are some trials where ceftazidime and imipenem was compared and there was no difference in mortality. Addition of ceftazidime and Ceftran versus ceftazidime, there was no difference in mortality. The idea is that you have to start, you have to think of milioidosis and start early with empiric therapy, and then you can read about what the intensive and eradication phase for milioidosis is. So I leave with the take-home points. I have 4 take-home points. The first is that you should make a syndromic diagnosis. If you don't make a syndromic diagnosis, it is very, very difficult to choose the antibiotics that you want to give. For example, there are antibiotics that will not penetrate that much into CNS or will not have that much urinary penetration. So you have to know that what is the syndrome that you are suspecting. The second take-home point is that if you have a critically ill patient, go as broad as possible. It has to be judicious, but to improve mortality, you have to go broad. Broad doesn't mean I will start everyone with meropenem and vancomycin. It might not work for your patient. It might have a lot of side effects. But based on your syndrome, if you're making a syndromic diagnosis of community-acquired bacterial meningitis, give ceftriaxone, vancomycin, ampicillin if the patient is elderly. So go broad in critically ill patients. Know your resistant bugs. This is very important. If you don't know your local epidemiology, at least you have to know what is the current situation in India. You cannot follow Western guidelines. This does not work in infectious disease, unfortunately. You have to know what are your resistant bugs, and based on your bugs, you have to choose your therapy. Something that is very important is that whether the patient is community-acquired or hospital-acquired, that difference will make a huge difference. For a community-acquired pneumonia, I am okay with ceftriaxone or azithromycin, but for a hospital-acquired pneumonia, there is no point of giving either of these antibiotic. And the last point is know your antibiotics. What is their efficacy? Start with full doses as much as possible. Even the patient has acute kidney injury, start with a full dose because the patient is going to die because you did not give a full dose of antibiotic. Renal modification is important for patients with chronic kidney disease. Penetration is very important. Aminoglycosides do not have good penetration in brain. So if you start with aminoglycoside alone for a bacterial meningitis, does not work. It does not go into abscesses where there is anaerobic environment. So you have to know your antibiotics also. The last message is that there are a lot of great ID physicians in Calcutta. If you have any doubt, contact them. Thank you.
Thank you, Dr. Nitin, for your wonderful presentation. Here, those of you who do not know Nitin, so he's most of the slides where there was this beautiful birds are clicked by himself. He is an avid nature lover, avid bird lover, as well as what we say is an avid bug lover. So Nitin has always been very critical of giving antibiotics. We studied together in our postdoctoral course in Delhi, and he was one of the physicians who use the least antibiotics among the IT physicians. And what Nitin has told today is really something to ponder upon. Number one is, if we take his messages, we very commonly see in complicated urinary tract infection patients that the patient has received nitrofurantoin or fosfomycin based on sensitivity data and has landed up in urosepsis in a hospital where some other antibiotics could have been given. So this is one message from Nitin's presentation that I would like to again reiterate on. Second is the vertebral osteomyelitis. Truly, right now in my setting in AIIMS Kalyani, I have received in last 2-3 months, I have seen 3 elderly male patients, all diabetic, presented with 1 staphylococcal and 2 gram-negative vertebral osteomyelitis. Both gram-negatives were Klebsiella, who were detected and were being treated as tubercular osteomyelitis, means tubercular TB spine, and was worsening and came to us. We went for invasive diagnosis. And as Nitin has rightly mentioned about brucellosis, so in West Bengal, we have seen in the last 2-3 years, we have seen a different type of brucellosis outbreak. So we have seen not wild brucellosis, but brucellosis among the paraveterinary workers who were handling the S19 brucella vaccine, which is basically a live, supposedly attenuated strain which has some morbidity in the human beings. And while handling this, the paraveterinary workers, I actually visited the scene of the vaccination and tried to do an epidemiological investigation. The animal resource department helped us a lot. We have seen that the paraveterinary workers have some dramatic ways of giving the vaccine. They make it air-free like the filmy way, and they give a few drops out of the syringe, which creates an aerosol in which they themselves become susceptible to. And we have identified at least 3 couples where these brucellosis was transmitted to the women in the home of the paraveterinary worker, the spouse of the woman, where the women was nowhere exposed to the cattle or the vaccination scene. So Nitin is absolutely correct when he reminded us about brucellosis. Regarding the last case of melioidosis, I would like to say, in recent times, I have seen a recurrent brain abscess case of melioidosis from West Bengal. We have seen liver abscess with melioidosis, and truly, it's very unfortunate that we are not doing cultures properly, and we are not, taking cultures from right sample, right amount, right volume, that we are missing these cases. And most of the Bengal's cases of melioidosis and histoplasmosis, which is not a part of acute febrile illness, so he did not mention, is going and getting diagnosed in CMC Vellore or in KMC Manipal or in AIIMS Delhi, and we are actually missing this. So one information I would like to share, as it is a forum of what I understand is mostly private practitioners, and we also have some representations from medical colleges. At AIIMS Kalyani, we will be able to give you diagnosis for melioidosis and for other brucellosis and for many other diagnostic for tropical diseases, and you can send the patients to us, and we will do it at very nominal cost or almost at free of cost. And as always, Nitin has given a wonderful presentation. If there is time,
Nitin, I would one question. Regarding the brucellosis, you have shown in the spine that is there. So treatment, if I remember, so that is the doxycycline, rifampicin plus streptomycin. And we have got a doubt that it might be tuberculosis. So you started with streptomycin, rifampicin. So after 6 weeks, how you will go for it, that it was brucellosis or it was tuberculosis in that?
So the empiric therapy of brucellosis is not very difficult now. So the thing is that this is first is the use of scoring system that I wanted to point out, that based on MRI and clinical feature. There is a clinical scoring system also that we have
what
made.
You have shown.
This is just the MRI feature. There is the clinical scoring system. So this was the idea where you are working in a setting where you don't have investigations. So there you can use this to choose your empiric therapy. Now, there are serological tests available for brucella with good diagnostic accuracy. So, standard agglutination test is something that is very, very helpful, or you can use an IgG brucella serology test. So, if either of them are positive, you start with brucella because your chance of this being brucellosis is very, very high. What people often do is that mixing two regimens together. So, you give ATT, HRZE, plus you will add doxycycline for brucella. Now, streptomycin does not feature into TB treatment regimen at all. So, you add 2 weeks of streptomycin. The problem is that it is very difficult to follow up how long you give. TB treatment goes for
9 months to 1 year.
So, the government recommends the 15 months for spondylolischitis. Yes. The problem is that if this patient was brucella, they could have been doing well with 3 months of treatment. So, do you want to give 15 months? So, the idea is that first coming to a reasonably good diagnosis that I am reasonably sure this is TB or brucella. When you are reasonably sure, you can treat accordingly. So, Sayantan, standard agglutination test is there now in Calcutta.
Is there chances of false positive with the agglutination test for the brucellosis?
So, at least in the setting where I am working, standard agglutination test, if the titer is more than 1:160, very, very unlikely that this is not brucella.
Thank you.
So, along with your
Number one is that brucellosis, it is written in textbook also, must always be considered in a case of spinal tuberculosis, number one. Number two, the site, usually it is the thoracolumbar or above. Cervical spine may be involved in tuberculosis. Lower down it is less common, but still it may be involved. MRI wise, the anterior elements are more involved in brucellosis than posterior one. And abscess is more common and much more in tuberculosis than this. Regarding the antibiotics, usually what we used to follow is streptomycin plus doxycycline. Then the triple drug has come with rifampicin and all. Certainly in clinical practice, there are occasions when we do use, we are forced to give antituberculous medicines as well, because we don't have so much diagnostic facilities.
So, sir,
so
you rightly
that
pointed
case, what
out,
should we do?
all the points that you have said is there in this scoring system that we have created, and the whole idea is try to make a diagnosis and start with one therapy. There might be situations where you have to use two. In general, for us, the serology for brucella has not failed very often. So, IgM brucella serology can be false positive, but standard agglutination test or brucella IgG is usually very helpful. So, what we do is that if we have made a diagnosis of brucellosis based on our scoring system, there is a clinical scoring system also. With both, if it is pointing towards brucellosis and if standard agglutination test is positive, we don't give anti-tubercular therapy. But if it is pointing towards tuberculosis, and the other thing is that again, what I didn't point out was that I am working in a setting where orthopedicians are very, very happy to do a biopsy. So, most of the times we make a diagnosis on biopsy. So, there are certain histopathological findings, you can get culture from there. So, in general, if you are working in the resource intensive settings, and most of you have that facility to do biopsy, if you are not sure, get a biopsy and culture it. I am talking about, for example, in AIIMS Delhi, there is such a high load that to get a biopsy from an orthopedician is absolutely impossible for a case of spondylodiscitis. There, you are forced to use empiric therapy. So, instead of using a broad empiric therapy, the idea is to kind of narrow it down to a diagnosis and then use the therapy. If you are in a setting where you are not able to make a diagnosis and you want, so there are a lot of things. So, brucella blood culture is often positive. When it is there, good enough. Serology positive, when it is there. So, there will be few cases, very few cases where you are coming to a conclusion that I am not sure this is TB or brucellosis, I want to give both. But very frequently, when we get referred patients, what we see is that patients are taking anti-tuberculous therapy for 12 months, 15 months, 2 years, but they eventually come out to be brucellosis. So, the idea is that.
In endemic zone where your clinical suspicion is very high, will you wait for blood film for malaria to become positive, or antigen test to become positive before starting anti-malarial treatment? Because I have seen so many patients who responded, complicated patients, who responded to anti-malarial test very nicely, but both the tests were negative.
So the thing is, sir, that the artesunate or RT-methyl lumefantrine combination that you use has an impact on other organisms also a little bit. So the first thing is that one, I am working in a setting where malaria is now non-endemic. I have, like I said, I have seen in 5 years, if I have seen 300 cases of scrub or 1000 cases of lepto, I have seen 3 cases of malaria here. The other thing is that malarial antigen tests for Plasmodium falciparum and Vivax are usually good enough. So you do not need a blood draw. You can just do a pinprick and do the antigen test. There are antigen tests which will not change with the treatment response. So for example, HRP2 based test, even if you have treated, it should be positive because it takes time, the half-life is longer up to 28 days. An LDH based test will respond. So, but there are both possibilities. What you are saying is that you have treated empirically, later on it came out to be negative. There are 2 possibilities. One,
No,
you have used that.
patient responded very nicely.
Sir,
In a complicated case, they responded.
Sir, what did you give?
Artesunate.
Art-
Because complicated case,
Right.
always artesunate is only indicated.
Right,
Not chloroquine.
right. So if you are using artesunate, the idea is that whether a different organism has responded to artesunate, that is one possibility. Second is that you are using a test which is dependent upon the treatment. So the treatment has killed. So artesunate works very, very fast. In 24 hours, your load is going to reduce by 50%.
We have taken blood film before giving. It
Right.
was negative.
Sir, that's the thing. So it is unlikely that that would be malaria if the malarial films are
Because
negative.
these malarial strip, they are antibody coated and they require maintenance
Antigen to
of
be
cold chain.
all. So sir, the commercial tests vary. In general, the sensitivity is 100 parasites per microliter of blood. The average parasitemia in Vivax is close to 4,000, 5,000. In malaria, it is in lakhs. Falciparum malaria, it is in lakhs. So if your test strip is good, it should ideally be positive. For ovale or malari, which is not common in our setting, it can happen that the antigen test is negative.
Yeah.
It is possible that the kit that you are using is not good.
We are getting more complicated Vivax rather than
Right,
falciparum
absolutely,
nowadays.
sir.
Dr. Gupta, how much importance do you give on carbar from rectal swab regarding meropenem resistance?
Carba are from?
For carbapenem resistance from rectal swab.
So, this is a whole different can of worms. So, in general, if you have a patient where you are suspecting gut translocation to be the source, then you can give some importance. But the point is that anyways, in most of the tertiary care settings, the patients are anyways carba resistant. So you have to use an antimicrobial that is going to cover the most common mechanism for carbapenem resistance, which is NDM and OXA48. So this is what you're going to do any which ways. Let's say I'll give you an example. If you have a patient who gets febrile neutropenia, where most likely cause of the worsening in the patient with febrile neutropenia is gut translocation. There, if before development of that, you did a carba from gut swab, that is okay. If you have a patient with urinary tract infection, I would not focus on rectal swab.
Thank you. Thank you.
We'll conclude. Sir, fine. Sir, one last question, sir.
Suppose hello, sir. Elderly people of 68, diabetes, having community acquired pneumonia,
Sir.
getting doxycycline and septum. How long we should give? 7 days or 10 days?
Sir, community
Patient-
acquired, sir, for community acquired pneumonia, it will depend upon whether it is a mild community acquired pneumonia or moderate severe pneumonia. The idea is that the minimum duration of therapy for community acquired pneumonia has been established. It is 3 days. So then rest of it will depend upon how fast have you responded. If you are afebrile for 24 to 48 hours, if you are not oxygen dependent, then you can stop the antimicrobial therapy if it has crossed 3 days.
Another question, what is about the azithromycin and typhoid? The dose is
Azithromycin in typhoid.
Azithromycin.
Yes, sir.
1 gram for 7 days or 10 days?
Sir, 6 days is enough for typhoid.
1
For
gram.
azithromycin. You can start with 1 gram on day 1 and reduce to 500 mg for 6 days, or you can give 1 gram for 5 days. Either ways, it is okay.
Or for in case of children,
Sir, for children, it has to be weight based.
10 milligram per kg per.
Sir, I have very limited experience with children, so I will not be. Shantanta, if you want to add. I have very limited experience with children, so I will not be able to help, but Shantanta.
Yeah, so 20.
Thank
20.
you. We'll conclude this session. Yeah. Amazing. It's a very nice, very interactive session. Dr. Nitin Gupta, thank you very much.